Can you hear me? Okay. Don't stop that. Hold that clock. Hold the clock. Dave's got a lot to say. So I'm a family physician in Anderson, South Carolina, which is basically halfway between Atlanta and Charlotte.
And nowhere.
In the middle of nowhere. We have about 200,000 people in our county, and we've been doing swimming upstream, I like to say, for about 3 years, doing direct primary care. For the first 3 years I was in practice, there was a slow grind, getting most of my patients from urgent care that I was doing as well. So when you're a slow grind, there's, you have to do a little moonlighting on the side. There's some things you have to do to make it work. And then as we talked to community leaders and people in our in the healthcare area in our community, began to learn that our county administrators really wanted a different plan. They were on a Blue Cross fully funded plan. One of the county council persons lives in my community, and talked with them, and they really wanted to make a change. So it took about 2.5 years for them to really decide they wanted to make a change. We brought in people for them to see how it works. We brought in a guy from Union County, North Carolina, who had transitioned into direct primary care. We let them see how that worked. And so they finally pulled the trigger, and luckily we were able to get them connected with Dave Contorno, who knows direct primary care quite well, which was a good thing for us. And so some of the concerns we had transitioning, from a pure DPC practice, and we're going to jump in with a large employer now. Is it going to feel like we're going right back to insurance? Are we going to be dealing with prior authorizations? Are we going to have to call to get everything done? So those are some issues that we were concerned about. Luckily, we had Dave Contorno, who really worked a really great plan, spent a lot of time with the county, and put a lot of effort into crafting a plan that was really useful for the employees, to drive the employees to a direct primary care model, because they have two different models. They have a standard plan and a direct primary care plan. And we were able to get we have 957 employees roughly, and almost 1,800 covered lives, something like that. And we were over 1,000 people total were able to transition to direct primary care between 3 different offices. And so I started out with about 300 people in my clinic on December the 29th, 30th, and January 1 I ended up with 618. So I gained 300 patients overnight. So that has its challenges as well. And luckily we had Dave Contorno to guide us through some of those things, try to make it better, try to do some incredible things that most DPC clinics haven't seen, where you're not having to worry about prior authorizations. He took a lot of stuff away from the traditional plan, which really helped us out. And so I'll let him talk about crafting that.
So my name is David Contorno. I'm a broker consultant, and I've been doing it for 24 years. And admittedly, for the first 17 or 18 years of my career, I operated in the traditional manner, commission-based, buca bought and sold and paid for. And I transitioned, and so as I moved into a world with no PPOs, with no carrier-based TPAs, with nobody telling me what I can and can't do except what is truly in the best interest of my client, and what you guys are accustomed to is changing the revenue model in a way that aligns the incentives, right? That's what I had to do. That's what I did first, actually, was I changed my revenue model. I said, this whole commission backdoor deal is ridiculous. And I'll point out one of our partners in the audience is One Beacon, who does stop loss on a lot of our clients. They recognize the discounts that should come with properly functioning plans with DPC, and they can attest to the fact that I never take commission, never take overrides. It's forbidden in my contract. So we're aligned. We want the client to get the outcomes they want, which is usually lowering costs. One of the things I think America is unfortunately somewhat blind to is the really low quality of care that we generally receive in this country. So I often have to educate them on that and talk about how DPC fundamentally changes that. But when it came to the plan, in this case it was a municipality, so we had a few restrictions that were kind of interesting. Number one, the employee-only premium had to be 0. So when I build plans and I want employees to take one plan over another, I can often do it in terms of how much comes out of their paycheck, but I couldn't do that here. And the county wasn't quite ready to let me build a DPC-only plan, or a plan where that was the only choice. So what we did is we built 2 plans. one in which the member could choose and see any doctor they want. There's no PPO network. We have proper pricing methodologies built in. We have direct contracts with many of the providers in the area. And we match their Blue Cross and Blue Shield plan. Then we created this direct primary care plan. And a lot of the success is actually due to Shane and his partner Amy, because being in a somewhat rural county, everyone knows everybody. And they already had a lot of patients within the county that were already coming to them. And if they weren't patients, they saw them at church or at the grocery store. And so there was credibility in what DPC can do, and that was really helpful in doing this. And the way we built the plan was we said to the employees, okay, you're going to pick at open enrollment the plan where you can see anyone, or the plan where you have to go through the direct primary care office for all your non-emergent care. And if you don't, it's not covered. But if you do, even if the direct primary care provider refers you out to a specialist, everything is covered at no cost. There is literally no copay, no deductible, not just within the DPC, but within every specialist, within every hospital encounter. I think we put a small copay on maternity because we wanted to drive them actually to the lower C-section rate facilities and so on. And we made it the best benefits that they've ever had. Now, what's interesting, so we had some bumps in the road. So for example, if a patient came to Shane and Shane said, you know, you really do need to go see an orthopedist, how do we get to the TPA that he did in fact refer them to that specific orthopedist so that the claim can be adjudicated at 100%? So we created a simple form. We wanted to keep it as easy as possible on them, but we needed to know that. So we created a really simple form that they fill out and email in, and it basically says, here's the patient, here's the doctor we're referring them to, here's the diagnosis code, and that way we get a little bit of data out of that too. So we can start to track it. We can see how often is he referring patients out of the primary care home. How does that compare to other DPCs that we have within the plans? One of the things that we have talks with, and I had this talk with Shane as well, is I said it's not only your responsibility to treat them properly when they're in your office, but when they leave your office, you are their Sherpa. You are their second opinion. You are their guide through the rest of the healthcare system, not only to help make sure that everything's being done as properly as possible, but most importantly, to pull that patient back into that primary care home the second that they possibly can. So they have to fill out that one form. We get from him regular reports on the percentage of members that were sent to him that have done their initial intake. We want 100%. We're up to what, 70, 78%, somewhere in there? And the plan went live 1/1, so it's 4 months that's been going on. And I think someone said it earlier, but it's like, are the healthy people taking this or the sick people taking it? And we saw a really good mix of the two, but I feel like it was more the chronic people that gravitate towards it. So we've had a few bumps in the road. Initially, I started off a little conservative where we had a lot of the same medical management and pre-cert on just the whole plan in general, but we then completely lifted from Shane and his practices. We also have built into a pediatric DPC and an OBGYN DPC as well. So all of those doctors now have no pre-cert, no prior auth, no step therapy requirements. Whatever they say goes and is covered at 100%. No member responsibility, 100% plan paid. Now, it's really early on, but I did look up the numbers, and so far, just a quick financial overview, the max cost under this self-insured plan was going to be around 15% less than the fully insured rate. So even in a worst case environment, they would have saved about 15%. However, we're currently running, and I did take some claims lag into account, a little bit south of 50% below that. Okay, so we're talking somewhere around a 60-65% reduction so far in total spend, which is not out of line with us. We normally see a little less than that, 40 to 45, 50%. But what I think is most important, and what I think is going to impact next renewal in terms of the open enrollment and the plan decisions, is the member feedback from those that chose the direct primary care plan has been overwhelmingly positive, where it does a couple things. First of all, the county is reassured that they made the right choice, right? They know that their employees are liking the care that they're getting. But I think it's going to send even more patients into that plan next year, where perhaps we can even get rid of that other plan completely and really control the proper clinical steerage within the plan. And I think we're going to see this county, we're going to start to track things. So for example, they have talked to us about the prison population. They have to pay for care within the prison population. And one of the things that we're going to track as a result of it being a municipality are things like opioid overdoses. Because I really think that we're going to have a positive impact on what's going on in the street. We're going to see less overdoses. We're going to see less people going to prison. We're going to see improvements that extend beyond just what we traditionally think of under healthcare and start to impact some of the socioeconomic things that we're all struggling with. So I'd like to toss it back to Shane for a minute because I think it's important to talk, Shane, about some of the growing pains that you had as we all of a sudden sent you these, hundreds and hundreds, and wound up being close to 1,000 new patients, essentially quadrupling your practice within the course of a few months. You had some lead time for that. You already had some growth in place, but talk a little bit about how you handled that, because I think to some of these people, they're probably saying, oh my God, that'd be amazing if I got 1,000 patients overnight. And some of them might also be saying, oh my God, what the heck would I do?
Yeah, blessing and a curse. Yep. So the way we handled it is we tried to get in front of it as much as we could and trying to get information from the employer as soon as we could, how many people signed up for DPC. And so we were calling every week, how many is it up to now? And so when we finally got the numbers, we gave cards, a lot of printed cards from Vistaprint or somewhere. Basically, that gave them information directly how to sign up for our clinic, step by step. Hey, here, go online, you sign up for our clinic. And they began to start enroll actually in November. People were starting already to put their information in our computer system. And so we also had a very good office manager, Caitlin, who basically spent a lot of time getting those patients pre-scheduled. So went ahead and emailed them multiple times, gave them our information, went ahead and had most of them before the end of December. Almost everybody already had an initial visit already scheduled. Now, it may not have been until April, but they had an initial visit on the books. And we let them all know, hey, if you're sick, if you need refills, something in between, don't wait. Call us ahead. We'll get you in. We did everything. We stayed late. We did whatever we needed to do to get our old people taken care of and get all these new people onboarded. So we're just now getting through everybody. It'll probably be next week we'll finish everybody up.
And, so from the member perspective, we did hear some longer wait times for a little bit. That's come back down, but we were monitoring that. I think overall, we radically and fundamentally changed the health of this county, and they're the largest employer in the county. They are deeply embedded in the county, and more importantly, it's given us credibility now with other employers around the country, and certainly in that area to do that. So that dovetailed, for example, into talking with Michelin, which is 55,000 employees, headquartered right outside of the county that they're based in. And so it really becomes a community thing, and I think that's important. And he mentioned about getting the info into a system. I do want to talk about with HintOS, with the new HintOS, and through some organizations that I'm a part of, like Health Rosetta, we're actually in the process of creating a direct link so that when employees enroll in the plan, that feeds into Hint automatically. It goes into their records automatically. The outreach starts automatically from Hint. They're set up. They know how to build the plan properly instead of us doing the manual feed. So that's happening throughout the course of this year, and we're making it more and more embedded. And for those advisors that are in the room, brokers, because I know there's a bunch, I know it's tempting, and I think for the doctors too, it's tempting to say, hey, let me bolt on to your Blue Cross and Blue Shield plan. Let me, keep what you have, because I know getting rid of that's scary, but let's throw this on. And I really would like to caution that, because one of the things that I'm afraid of as we change healthcare is that if it fails in any capacity, the large carriers, the status quo players that don't want this working, are going to use that failure as an excuse to all the other employers as to why to not do it. So let's be calculated, let's share, let's collaborate. When it's worked, let's share it. When it hasn't worked, let's share it. And let's keep this movement going, and let's make next year's Hint Summit even bigger than this one. Thank you.